Friends, the first brain tumor or the CNS tumors that we are supposed to learn is meningioma, right? Cell of origin of meningioma is the meningothelial cells of the arachnoid. Arachnoid, fine. Arachnoid matter. The meningothelial cells of the arachnoid matter are the cell of origin, and it is the most common primary brain tumor in adults. That means primary brain tumor simply means that it is arising de novo inside the brain itself. So it is the most common brain tumor in adults which is arising within the brain. Secondary brain tumors means it is metastasis. So primary brain tumor means the brain tumors which are arising in the brain itself. Remember, it has a strong prevalence of progesterone receptors inside it. So there is a lot of progesterone receptors inside it, typically because it is having an increased prevalence in females over males, and obviously during pregnancy or whenever in a female the progesterone levels are rising due to the increased amount of progesterone receptors which are present on the surface of this particular tumor. There is an increase in the symptoms shown by the patient, and the patient can deteriorate because of the increased level of progesterone attaching to the receptors which are present on this particular tumor. So remember, it is seen more in females than in males. Okay, it is seen in typically NF2 mutation. This is something that we will not forget. Neurofibromatosis 2, and if the patient is suffering from neurofibromatosis 2, that particular person will have together these two things, that is acoustic neuroma plus meningioma. So the meningioma and acoustic neuroma can together coexist in a patient who is suffering from NF2 mutation, right? And you can also remember TRAF7 mutation. Okay, this is TNF receptor activating factor. Okay, that is called as TNF receptor associated factor 7. Okay, so that is TRAF7 mutation. There also this is very much prevalent. Fine. If you see this particular image that I have taken, see, this is the histopathology of that. You can see these kind of structures. So these are the concentric rings of calcification. Concentric rings of calcification, which is not very much classical of this. It can be seen in multiple other tumors. But yes, these are classical of certain tumors in the body. Now these structures you will call by the name of schwannoma bodies. Fine. So these are called as schwannoma bodies. So these are the structures which will help us to understand that obviously this is meningioma or any other tumor coming in the list of the tumors which have schwannoma bodies. So these are concentric ring of calcification. Remember that. Fine. So this is a concentric ring. You can see how beautifully it is arranged in this particular picture. This is a concentric ring of calcification. This one, everything. And the cells are arranged in whorls. Fine. The cells are arranged in whorl-like arrangement. Fine. And these cells are actually in a syncytium. So you can see this particular syncytium over here, which means that the boundaries of the cells are not visible. The eosinophilic content of the cells are visible, and also you can learn that inside the nucleus, which is not very visible over here, you will be having intranuclear inclusion bodies. Fine. Inclusion bodies are present inside the nucleus. It has an eosinophilic cytoplasm which is arranged in the form of syncytium, which is arranged in the form of whorls. So these are the whorl-like arrangement of the cells, isn't it? These are the whorl-like arrangement of the cells around the schwannoma bodies. Fine, let's go into further more details. We are supposed to learn certain other things over here. We are just supposed to learn the classification also. Sometimes they can ask that also there. So yes, see, whorls of cell-like arrangement can be seen, schwannoma bodies are seen, intranuclear inclusion bodies can be seen, and syncytium of eosinophilic cytoplasm is seen. Last, to end this, we will just talk about the classification. So grade is actually based on the WHO grading system. WHO grade 1 is there, that is the normal meningioma which you can think of, which is normally given to you in the exam. Grade 2 is atypical. So here the atypical cells can be seen over there. We know what are the atypical features of a cell, isn't it? Increased mitosis, hyperchromatism, increased NC ratio. These kind of features will be present in atypical, in the cells, in the malignant cells that are coming there in the tumor cells of grade 2 meningioma. And as it proceeds into grade 3, the atypical features of the cells are going to increase. It so much increases that it becomes anaplastic cells, and now it is malignant. So grade 3 is malignant, where atypical features are going to increase from grade 2. So as we proceed from grade 1 to grade 2, the atypical features are going to increase, and from grade 2 to grade 3 again they are going to increase, finally leading to malignant meningioma, which is infiltrative in nature. Okay, so this is malignant, it has the poorest prognosis. Grade 3 has the poorest prognosis. Fine. Grade 1 is again divided into further these many subtypes. See, meningothelial simply means that your eosinophilic cytoplasm which is arranged in the form of syncytium. These kind of characteristics which we have discussed over here, these are typically the features of meningothelial fibroblastic. Fibroblastic simply means meningothelial normally. Psammomatous has a lot of psammoma bodies. Fine. Secretory has a lot of glandular appearance. So from the name itself, we are getting an idea of those things. At least remember the names for the exam. Secretory means a lot of glands over there. Psammomatous means a lot of psammoma bodies will be there. Fibroblastic means a lot of fibrous structures will be there. Cells will be in this elongated form. Typically, fibroblasts are those cells which are elongated, isn't it? We know the structure of a normal fibroblast. It is actually an elongated cell, and this secretes a lot of collagen, and that particular collagen will be present over there. So fibrous structure will be there everywhere. Meningothelial, it contains this whorls of cell arrangement, syncytium of eosinophilic cytoplasm, which is typically seen over here. Fine. Transitional simply means that meningothelial and fibroblastic features are together present over there. So the first one is meningothelial, second one is fibroblastic. If at all it is showing both these features, both the features of meningothelial plus fibroblastic, you call it by the name of transitional. You say that it is in a transition between both these kind of tumors. Okay, so we are supposed to discuss one more important slide over there, that is schwannoma. So let's proceed into that. So guys, let us talk about schwannoma here. Schwannoma can occur in multiple parts of the body, but remember, as a part of ENT also we know that the most common nerve affected is the eighth nerve. Eighth nerve, right? It is vestibulocochlear nerve, and it has a vestibular part as well as a cochlear part also. So the vestibular part is the most common site, right? So it is an extremely slow growing tumor, a very slow growing tumor, and as it grows continuously, it keeps on growing. It can actually affect multiple parts of the brain, and that can lead to secondary problems which are associated with that. So let's say that it is associated with the facial nerve, seventh nerve, because seventh nerve, eighth nerve, and the labyrinthine vessels and nerves are coming inside the the internal auditory canal, isn't it? So there it can get affected. What, seventh nerve? So the facial nerve is affected, so that can lead to facial palsy, which is a possibility, and it can go and affect multiple other sides of the brain like this. So it's a benign tumor. Okay, it is an encapsulated tumor. It can occur in soft tissue, internal organs, and nerve roots. Right? Not just the nerves. It can also occur on the soft tissue and internal organs. So yes, as far as ENT is concerned, most common nerve affected is vestibular part of seventh nerve, right? If you talk about the mutation here, sporadic is there and familial is also there. Sporadic is the most common compared to the familial, and familial, as far as familial is concerned, how can we ever forget something called by the name of neurofibromatosis? This is something that we can never forget whenever we talk about meningioma and schwannoma. Meningioma and schwannoma can together coexist. Meningioma, schwannoma, ependymoma can together coexist in a person who is having schwannoma. I mean, neurofibromatosis 2 mutation, NF2. Familial neurofibromatosis 2 mutation, right? And whenever a patient is suffering from NF2 mutation, there is a gene on the 22nd chromosome called as Merlin gene. Okay, Merlin gene is associated with contact inhibition. See, what do you understand from this? Contact inhibition is a very normal property of all the cells, that once two cells are in contact, it will not keep on dividing. Okay. So, which is a benign feature. The moment this is lost, when the moment this gene is lost, gene loses its action, the contact inhibition, which is mediated by the E-cadherin, it is mediated by E-cadherin, right? You might have heard of E-cadherin, isn't it? In breast carcinoma, you might have heard of a lot of things in this, isn't it? E-cadherin was taught to us in the neoplasia chapter as well as the breast chapter also. So yes, E-cadherin is lost. Okay, so you can say that contact inhibition is lost, and that is the clinical feature, very important classical feature so far as the familial and NF2 gene mutation is there, and this Merlin gene is an important gene so far as our understanding of the tumor is concerned. So let's go to the histopathology features now. Yeah, so that's it. Now, yes, if I just start talking about this particular histopathology image, the point to remember is here you can see the nuclei are more closely arranged. So this is called by the name of Antony A area, and this is Antony B area. So point to remember is in Antony A area, the nuclei are closely arranged, cells are closely arranged, and in Antony B area, cells are loosely arranged. The cells are spindle cells, okay? Spindle cells are present over here, and the nuclei in the spindle cells and the cells itself themselves are arranging in such a way that you have a row of nuclei over here, isn't it? This is the fencing arrangement of nuclei, or you can call this as the palisading of nuclei. So fencing or palisading arrangement of nuclei is present because of the arrangement of cells in the Antony A area. So this kind of a characteristic feature is seen in Antony A area, but that is not seen in this loosely arranged area called as Antony B area. Now, Here if you see, in this area there is a nuclear fencing, here also there is a nuclear fencing, and obviously there is an area which is internuclear area. There is no nucleus over here, so there is no nuclei here, but there is excessive nuclei in this direction, and here also there is nuclei. So this alternating band of nuclei with a nuclear area, these are called by the name of Verrocchi bodies. Verrocchi bodies are present in Antony A area. These are the alternating bands of nuclei, and in between you have an area where there is no nuclei. Okay. So yes, I hope that's all we are supposed to know over here. Remember these points. Let's proceed to the description of the histopathology. Right, Antony area, this is dense area, spindle cells are there, nuclear palisading, because the cells themselves are arranging in such a way, and the nuclei themselves will arrange in such a way that there is a palisading or fencing arrangement of nuclei. Verrocchi bodies are seen. Verrocchi bodies are alternating bands of nuclei with a nuclear area. Antony B areas are loose areas. Okay. Yeah, so with that we come to the end of this discussion. Now let's proceed to the next slide. Okay guys, so this is the slide of squamous cell carcinoma, which can occur in multiple parts of the body, but wherever they occur they show the similar characteristics. So first point to remember, this is a tumor of the epidermis. This is not a tumor of dermis and all those things. This is a tumor of epidermis. Please make a note of this. Okay, this is a tumor of epidermis. So this is your epidermis, this is the dermis in this particular Robbins image. So this is the dermoepidermal junction or the basement membrane zone. You can see that, isn't it? This is the dermoepidermal junction or basement membrane zone. But when I reach over here, it invades into the dermis. This is invasive squamous cell carcinoma. It invades into the dermis. That epidermis malignant cells invades into the dermis. Once they are inside the dermis, they will be forming these cell nest arrangement. Cell nest arrangement, right? You can see these kind of cell nest and cords of arranged cells, malignant cells have been arranged over here. Okay, so they are in the form of nest and cords, right? Then what they do is that if at all they are present inside the epidermis, stratum spinosum, stratum granulosum, these layers are actually called by the name of squamous cells typically. Now they will be secreting keratin there also. So here also they will be secreting keratin. Now this keratin which is here will be forming these clumps of keratin. These are called by the name of keratin pearls, right? Keratin pearls are the most classical, most characteristic feature of any squamous cell carcinoma. In the exam, you get a slide showing keratin pearls, then your answer is none other than squamous cell carcinoma. This is the most characteristic, most classical feature so far as an undergraduate is concerned, right? So this is the keratin pearls. These are actually keratin secreted by the malignant cells, which will be forming the clumps over there. And also you can see these kind of blue dots over there. That just means it is a lymphocytic infiltrate which is present over here. These are certain lymphocytic infiltrates which are present in between the nest. Okay. So what are the mutations here? Mutations are actually P53 mutation is possible, RAS gene is possible, NOT gene is also possible. So they can ask you the mutations in the questions that come along with the slides. Right now, okay, this is a tumor of epidermis. Just go through this. It invades into the dermis, right? They have nest and cord-like arrangement of cells within the dermis. They produce keratin pearls. This is the most characteristic. The moment you see this, you will definitely say that this is squamous cell carcinoma. Inflammation which is present along with in between the cell nest arrangement. Okay, so keratin pearls are the most important striking feature that will help you to understand that this particular slide they have given is obviously squamous cell carcinoma, and the slide will be focused to that kind of an area where there will be lot of keratin pearls. Now what are the risk factors? Just look at these risk factors. The most important risk factor is sunlight. Okay, then they have also mentioned in the Robbins that immunosuppression, typically a patient who has taken a lot of steroids after an organ transplantation and all those things, they will be having a high propensity to develop these kind of things. Industrial carcinogens like tars and oils have also been mentioned so as to cause this. Okay, now HPV is something that we should not forget because that is accountable for causing the cervical carcinoma in women, and we have a lot of risk factors associated with HPV in the topic of female genital system, right? And then these are the last things, that is non-healing ulcers. Obviously any chronic non-healing lesion in the skin have a increased chance of going into one of the malignancies of the skin. And finally we have this particular xeroderma. Xeroderma is actually a nucleotide excision repair defect, right? When nucleotide excision repair is defective, you will be developing a disease called by the name of xeroderma, right? And this xeroderma can actually come with it can actually present with any of the three: squamous cell carcinoma, basal cell carcinoma, malignant melanoma. Any of these three important very classical skin malignancies are possible in xeroderma. Okay, I mean xeroderma. Okay, so with that we come to the end of this slide. Let's proceed to the next one. Let us quickly go into the basal cell carcinoma, of which is having again fair skin individuals, sunlight exposure, ultraviolet radiation is again the most common risk factors for so far as this tumor is also concerned. Now mutation, as far as mutation is concerned, it is sonic hedgehog pathway defect. There are many genes playing a role inside this. So yeah, we have certain mutations occurring in with respect to the genes that are playing a role in this pathway, and that can lead to basal cell carcinoma. One of such genes is PTCH gene. As far as our PTCH gene is concerned, if a person is having a germline mutation in this, or a familial mutation of a PTCH gene mutation, is called by the name of Gorlin syndrome. Okay, so Gorlin syndrome is the familial mutation of a PTCH gene, and such a patient can develop basal cell carcinoma and medulloblastoma. Medulloblastoma is a tumor which is arising around the fourth ventricle inside the brain, and that typically shows a metastasis which is called as drop metastasis. Through the CSF it comes down, so we see that okay, drops of cells are coming down, so that is called by the name of drop metastasis, very characteristic of medulloblastoma, which can occur along with basal cell carcinoma as far as Gorlin syndrome is concerned. Now, whenever we talk about basal cell carcinoma from our chapter of neoplasia, one important point that we read over there is that metastasis is very rare. Sometimes even no metastasis can be seen over here. Okay, but what makes basal cell carcinoma very aggressive tumor is that it is locally aggressive, right? It is locally aggressive, so it occurs, the rod and ulcer form which occurs, in the line that is joining the angle of mouth to the tragus. So it is very aggressive. So that is why we say, why is it so? Because it is locally aggressive, and metastasis is rare. Can you give another example of a tumor which is rarely metastasis, which shows rare metastasis? We can talk about glioblastoma. So glioblastoma and the basal cell carcinoma, two examples of carcinomas which shows metastasis which is much rare compared to other tumors. So yeah, even no metastasis can be seen inside this kind of a tumor. Let's now talk about this particular histopathology image over here. You can see this is the cell nest arrangement. So again, how will you understand this? This is a epidermis, and then comes the dermis. So it is a tumor arising in the epidermis, and it goes into the dermis, where you have the nets arrangement of the cells, right? This is how the nets are arranged. Now if you talk about a single nest of the cell, see, you can see nuclei which are palisading over the external surface. So yeah, towards the periphery you will see palisading arrangement of nuclei. This is one of the most characteristic classical feature, palisading of nuclei. So whenever they ask you to write the features of basal cell carcinoma, do make it a point to write palisading of nuclei, and around this you have a clear area, and then comes the stroma. So if this is the stroma, this is that particular palisading arrangement of cell nest. This is the cell nest arrangement here, and these cells are having a big nuclei, atypical nuclei can be seen over there. All the other features of malignancy can be possible over there. It is a basophilic cell, and nuclei which are large will undergo this kind of a peripheral palisading, and this particular area is devoid of any kind of material over there. See, you can see, I think you can appreciate that area that I am demarcating here. Look in between the cell nest. If you just try to see here, this is an area where nothing is seen. So these are called by the name of retraction artifacts. So whenever we write an answer, do make it a point to write palisading of nuclei and retraction artifacts over there. It's an artifact, so make it a point to note that also. So yeah, neoplasm arising in the epidermis, squamous cell carcinoma, basal cell carcinoma, malignant melanoma, everything arises in the epidermis. Cell nest arrangement inside the dermis, and the cells are round cells which has prominent nuclei. I know it is an atypical cell, so obviously it has all feature of atypia, and it is a malignant cell, and it has a Scandi cytoplasm, and this big nuclei will be palisading in the nest arrangement. This is an important point. This is also an important point, and there is a lymphocytic infiltration in the stroma. You can see this. This is red lymphocytes are present in the stroma. So that is what I would like to discuss so far as basal cell carcinoma is concerned. Let's go to malignant melanoma now. So the next one will be malignant melanoma, right? Again, it's a neoplasm from the epidermis, and it goes into the dermis like this. See, whenever we talk about malignant melanoma, there are two types of growth here. So it can be a longitudinal growth. You can call it as the radial growth and the vertical growth. Okay, so initially what happens is that the tumor will grow within the epidermis in a radial fashion. So if this is the epidermis of this particular skin section, this is given over there. So the tumor will go in this way and that way. So it is a radial fashion of growth shown by the tumor cells. So initially we will be having some kind of macular lesion or a papule lesion a raised lesion can be seen, or a flat lesion. Typically it is said to be a flat lesion can be seen on the skin surface. And when it goes for a vertical growth, that means now it goes into the dermis. This is the vertical growth. It goes into the dermis. Then it forms a nodule. So nodule, as far as nodule in dermatology is concerned, what makes a nodule most important is that it has a deeper component. So a nodule is always felt by palpation, and while you palpate it, you see that there is a deeper component to it. So as it goes deeper, it is called by the name of vertical growth, and that leads to the formation of a nodule, and then starts all the trouble. Okay, so you might have read in the textbook about a melanocytic nevus transforming into a malignant melanoma. So yes, it's a risk factor for formation of malignant melanomas. Yes, so nest, cord and scattered arrangement of cells can be seen. So yeah, bizarre arrangement of cells can be seen in multiple formats, like cells can be seen in the form of nest or cord or scattered, whatever it is. Round or oval cell with eosinophilic nucleoli, right? Eosinophilic nucleolus can be present over there, but we are not going into so much of details in this particular image. We cannot appreciate that very much clearly in the image that I have taken over here. And the cytoplasm contains this granular melanin pigment. See, you can see here, that is the most characteristic feature by which we as a student understands what is malignant melanoma. But remember, whenever we talk about a tumor in a skin, like the way I approach it is by confirming that it is a skin. So yes, you can see the epidermis over here, stratified squamous keratinized epithelium can be seen here, and then comes the dermis below. So that is how it is always good to approach the tumors of the skin. So confirm it is a skin, then go to further details of each of them, and we can actually differentiate between the three cancers and even the tuberculosis. Slides that can be kept in the exam. Right, so far as the mutations are concerned, ultraviolet radiations. See, as far as the ultraviolet radiations are concerned, it is the most important risk factor here, and fair-skinned individuals who are especially living in the Western countries have an increased chance of getting the disease. Now, the point is that ultraviolet radiation, once it hits on the skin, what happens is it can lead to DNA damage, and DNA damage, gene damage can be there, and there are multiple genes which are actually associated, which is actually said to play a role in the development of malignant melanoma. So one of the most important genes so far as our textbooks are concerned, that is CDNK2A gene. This is the most important gene over there. Now once here there is a mutation in this gene, it leads to the decrease in P14 and P16, right? And then RAS is involved here. P53 gene is also involved in the disease, and you can see here BRAF gene and RAS gene are, first of all, these are the initiating mutation. So this is a benign lesion which is called by the name of melanocytic nevus. Then there is a telomerase activation. Remember, increased telomerase activity means cancer, right? Telomerase. So if there is an amount of telomere which is left, that means the cell is immortal. So that immortality is conferred by telomerase action, and then it goes on. Initially you have a radial growth within the epidermis, it spreads, and then comes the vertical growth. That means the moment it goes into the dermis, it is an invasive carcinoma. So till it have epidermis kind of spread, we call it by the name of benign nevi. Okay, and that goes into the dermis, then becomes malignant. So melanoma, vertical growth, and this means that it is forming, it is making itself very much aggressive, and that means the tumor is going to the next level of spread. Okay, and it can go for a heavy metastasis also. So as you go from this area to that area, the severity is increasing. So you have a lot of genes over here, PTEN, P53 gene. So this is how the whole progression is happening. So do remember these genes here, CD, K and 2A, and you can remember these also, right? Okay. BRAF gene has been given, RAS gene is also there. So yeah, it's better to arrange everything in this kind of format, so that can be very much good when you write an answer. So yes, Breslow thickness is which is the most important prognostic factor here as far as examination of that is concerned. We have a histopathology section, so we have the outermost layer of epidermis to the deepest layer of dermis. So yes, if I can just show you that, what I have understood is outermost layer of epidermis to the deepest layer of dermis, somewhere over here, till wherever you can see the tumor cells going there. Up to this much you will have to take as the length of Breslow thickness. As the Breslow thickness is increasing, that means the depth of invasion is increasing. Depth of invasion increases means the vertical growth is increasing. So therefore it becomes more and more invasive. That means it has a poorer prognosis. So yes, we will go into the infection of the skin, that is leprosy, and it is caused by Mycobacterium leprae, which is also an acid-fast bacilli. Mycobacterium leprae and acid-fast bacilli. It is very difficult to culture it, so we do it on armadillo and footpad of mice. So many points are there in dermatology as well as in microbiology. So as far as the pathology is concerned, let us actually go into these two images here. You know, Ridley-Joplin classification. You are actually classifying the types of leprosy into TT, BT, BB, BL and LL, isn't it? Tuberculoid, borderline tuberculoid. Then you have a borderline, which is the least common and most unstable type. So it will directly go into some other type within no time. Then you have a borderline lepromatous and you have a lepromatous type. So we have two extremes over here. As we go from tuberculoid to the lepromatous leprosy, one very important feature that we are supposed to remember is that the immunity of the person, immunity is very much reduced. So in TT you have high immunity and in LL you have low immunity. So whenever a patient is having high immunity, what happens is that these organisms which are present inside the skin, the organism present inside the skin cannot come out. So they are actually very much inside. So it is prevented from coming out. So that is why in okay. So whenever a patient is having low immunity, that means maximum invasion. Low immunity means it is very much favorable for the organism, so it can go for a maximum invasion. So whenever the organism is having a maximum invasion, the organism will be present in the dermis here, very much abundant in the dermis, and will not come to the epidermis. So in that case, there is a small area over here clearing. You can see a small clearing over here where nothing is present. So I hope it is very much visible for you. I have marked it as the Grenz zone, isn't it? So this is the Grenz zone. That is a very characteristic feature, the most classical feature so far as an understanding of the slide is concerned whenever they give you lepromatous leprosy kind of a slide in the examination. So yes, try to look for this kind of a Grenz zone. First of all, just confirm it is a epidermis dermis combination, epidermis dermoepidermal junction dermis combination. That means it is a skin section, and once you know it is a skin section, try to see this kind of a Grenz zone. If it is present, you have a lepromatous leprosy. If it is absent, you have granulomas inside, which is a tuberculoid leprosy, right? So yes, here you have a small clearing between the epidermis and dermis. This is the Grenz zone. Okay, so it is an unoccupied area, clear uninfiltrated area in the upper dermis, right? This is the dermis, and then in the upper dermis you have a clear uninfiltrated area. Because the patient is having low immunity, all the organism is deep inside, it can go directly inside, and therefore you have an unoccupied area over here, and all the immune reaction will be here only, right? Now as far as this is concerned, you have foamy macrophages here, isn't it? Macrophage which is full of foam, I mean lipid laden macrophages which has a lot of lipids inside it. That is why it looks foamy macrophage. And yes, these are called by the name of lepra cell. Okay, lepra cell. So if you take a small section, you will see that the lepra cells are very characteristically arranged in this particular way, very symmetrically arranged in a way, and it is highly packed arrangement. This is what is meant by the word globi. So globi is a typical feature of lepromatous leprosy, where these kind of foamy macrophages are present in a very peculiar arrangement, very constricted arrangement, what you can say, a very compact arrangement of the foamy macrophages can be seen inside the dermis, and you call it by the name of globi. And it is also given in the textbooks of dermatology that it is called by the name of cigarette pack arrangement, like cigar pack arrangement, where all the cigarettes are kept in a correct format like this. Right, so yeah, epidermis here, this is a very thin and flat epidermis. Just compare this with here with respect to this. You have a big epidermis over here. This is the epidermis and this is the dermis, obviously. And this particular line is the dermoepidermal junction or the basement membrane zone. So this is your epidermis and deep below is dermis. Now just compare the thickness of epidermis in tuberculoid to that of lepromatous. You will see that the thickness of epidermis in lepromatous is very, very thin. Right, you have a Grenz zone in lepromatous. Grenz zone will be present in that kind of leprosy where the patient is having low immunity, and this is the foamy macrophage appearance over here. It is not very easy to make out all the cells in this. It looks like a foamy appearance, isn't it? So this is what you see over there, and you see this is a stain. It was asked previously in the exam in our college. Fight for Faraco stains. This is FARACO. This is used for the purpose of staining. Okay, and you see lepra cells are crowded with acid-fast lepra bacilli. So this is what is used for the purpose of seeing the organism, or you can diagnose the lepromatous leprosy, you have a classical stain over there, and another stain is your Zeal-Nielsen stain, obviously. But White-Ferracco stain is used for the purpose of seeing the Mycobacterium leprae as well as Nocardia also. So as far as our tuberculoid leprosy is concerned, you can see here a lot of granuloma can be seen over here, isn't it? This is a granuloma that you can see, and there is no Grenz zone. You have high immunity, so the organism is not in a position to go deeper, so it is present in the superficial layers. See, very superficially it is present. So stratified squamous epithelium, dermis shows granuloma. So granulomas are a classical feature of tuberculosis. Similarly, if you are getting granulomas, you will call it by the name of tuberculoid leprosy. Definitely. Okay. You have there are giant cells, epithelioid cells, and Langerhans giant cells, isn't it? This is a very important feature here. Not Langerhans. It is Langerhans giant cell. Langerhans cells is a type of cell in the epidermis, and you have Langerhans cell histiocytosis where the number of cells are increased. But definitely this is Langerhans giant cell, which is a classical feature of leprosy. There is no Grenz zone. Why no Grenz zone? The organism cannot go deep inside because the immunity of the person is so high, so it will reside in the superficial layers. So therefore there is no unoccupied area in the superficial layer of dermis. Everything is occupied, right? And nerve bundles are also involved here. You might have heard of a lot of cranial nerve defect, and sometimes in an exam they had asked to mark the auriculotemporal nerve in one of the entrance exams. Likewise, nerve bundles are also involved over here. You have this glove and stocking neuropathy, which is associated with this. A lot of clinical features are associated with that. Now, make it a point to note that there are a lot of granulomas over here. And if I can zoom into this picture, which is not very much obvious, which is not very much possible in this kind of medium, you will be able to see the giant cells in that also, right? So the Langerhans giant cell can be very easily appreciated under the microscope when we see that. So yes, granulomas are a characteristic feature of, just like tuberculosis, you have tuberculoid leprosy, which looked like tuberculosis. That is why you have given this particular name. So yes, this is a granuloma. Here you can see a granuloma like this. This is also a series here. Series of granulomas can be seen over there. So that is how we are actually in a position to differentiate the tuberculoid leprosy and lepromatous leprosy. The White-Ferracco stain was asked in one of the exam, okay, as a sub question along with that. Formi macrophages, globi, right? So these are certain important points so far as our answer pertaining to a question on leprosy is concerned. Okay, so with that I'm just winding up this video. In the next video we'll go to other remaining kind of slides which are asked for the exam. Thank you.